So it gives me great pleasure to welcome the 2018 Henry Laws lecturer, Carol Ann Moulton, to the Southeastern Surgical Congress. This lecture is named after Henry Laws to honor his contributions to the Congress in the field of surgery. Dr. Laws joined the Congress in 1967 and served as president from 1997 to 98. He received the Distinguished Service Award in 2012. During his surgical career, Dr. Laws was in private practice, and he served on the faculty of the University of Alabama, Birmingham, serving as director of the surgical residency program at Caraway Methodist Medical Center, as well as being a surgeon at the Norwood Clinic. Dr. Laws had a passion for not only clinical care, but also for medical education. He taught me how to do a lap Nissen. He died on February 25th, 2014 at the age of 81. Carol Ann Moulton graduated from the University of Melbourne in 1992 and completed general surgical training, earning certification from the Royal Australasian College of Surgeons in 2001. She undertook several fellowships following this, including a fellowship in upper gastrointestinal and laparoscopic surgery at St. Vincent's Hospital in Melbourne, a fellowship in hepatopancreatobiliary surgery at Toronto General Hospital, and then a surgical education fellowship at the University of Toronto, earning a Master's of Higher Education in 2006, and then a PhD in 2010. She's an associate professor in the Department of Surgery and co-director of the HBB Fellowship Program at the University of Toronto. And she's the medical director at the operating room at Toronto General Hospital. In early 2010, Dr. Moulton became a scientist at the Wilson Center at the University of Toronto, and she is the recipient of the Early Researcher Award from the Ministry of Research and Innovation. Her research has been supported by the Medical Council of Canada, the Royal College of Physicians of Surgeons of Canada, and Physician Services Incorporated. Dr. Moulton's research program focuses on understanding the complexity of surgical judgment, the development of surgical expertise, and underlying causes of surgeon error. I make reference to her at least once a week in the OR and 3 times a week at M&M conferences. So I'm delighted that we'll all get to hear firsthand from her on her illuminating work that she has done over the past decades. Dr. Moulton.
Well, thank you very much for the invitation to come and present at such a named lecture. I always have the, I don't know, I feel honored, I think, when I get the invitation, as it's work that's actually very close to my heart and work that I've actually invested a lot of my time in over the last decade. I'd like to start with a story. When I was a PGY1 or a PGY2, some of you may have heard this already, but it's a very striking story to me and kind of sits in my memory. I was in Australia, and my staff at the time told me I could do my first inguinal hernia repair from skin to skin. And I remember feeling kind of elated and a bit nervous and, preparing, reading, making sure I kind of knew it all. And walking into the operating room, doing the incision, and remember feeling like this does not feel the same as when people are standing there looking at you and watching over you. And then every strand that I cut seemed to, I had to kind of analyze it. Is this okay? Is this, an artery or a nerve that I shouldn't be cutting, or the vas? But I remember actually doing it quite well, and in my, elation, I wanted to go and actually celebrate with a patient as this 24-year-old man was waking up in recovery. And I remember the feeling of him waking up in distress and in severe pain in his testicle. And I'd never seen that before, and I didn't really quite know what was going on, and my mind started racing about what could I have done. Maybe that thing was something I shouldn't have cut or shouldn't have tied off, and I just remember those kind of racing thoughts. And I went home and tried to kind of put it behind me. I thought the patient was doing okay when I left the hospital, but I remember it kind of ruminating about what could I have done, and all these kind of thoughts racing. Went to bed, called a couple of times during the night, and I finally had to get out of bed at 3 just to make sure the guy was okay. And I remember walking into his room, the lights were off, and he was sleeping, and I woke him up and I said, "I just got to feel your testicle." And it made perfect sense to me, but obviously to this guy it was a bit odd. But I remember that feeling very distinctly, and the feeling like I am not cut out to do this. You know, the guy was actually okay. He went home the next day. This was not even a complication, and I wrecked my whole night and evening worrying about it, and now I'm tired and kind of wrecked for the next day. And I remember that feeling of maybe I'm just not cut out to do this. Surgeons around me seemed confident, surgeons are capable, and I felt like I was full of uncertainty and I had a lot of anxiety. So fast forward several years now, and I'm become interested, after my fellowships, became interested in studying this construct of surgical judgment, trying to understand what is in our heads as surgeons, and why some surgeons seem to have good judgment, some others don't, why sometimes a good surgeon will have good judgment and different times they have poor judgment, and just trying to understand really what this construct of judgment was all about. I did some observations in the operating room, and we identified a phenomenon that I found quite intriguing at the time, and we eventually called it slowing down when you should, and this was the focus of my PhD. Understanding the transition between what we would call as kind of fairly routine work, and then transitioning and slowing down when we recognize something wasn't quite right, or something was in the field that we didn't kind of quite understand, or we were worried about, or we recognized a very critical part of the procedure. We focus, we shut down, and we concentrate on the field. And so we actually did qualitative work just around this phenomenon, trying to understand what led to it, what caused it, what does it look like, do surgeons recognize it, and all the rest of it. And the research that we did was qualitative research, so we went into the field where surgeons were operating and we observed this phenomenon and we talked to them about it. And we also went out into the literature to see, one thing I've learned over the last decade or and a bit of my research is that any phenomenon we're interested in, or anything we're interested in surgery, can often be added to or informed by research that's outside the field. And so we actually looked outside the field, and I just wanted to share quickly with you today a theory of cognitive capacity that I actually think about almost every day of my life since I've learned it. This idea that we actually have a fixed cognitive capacity to actually pay attention to things, and that's the dotted line at the top. And we function within that that box of capacity. And so what we're doing actually occupies all the effort that we actually are making at any given stage or any given moment is actually utilizing some of that capacity. And sometimes we have spare capacity where we could actually kind of enlist something else and multitask. And as we become expert at something, there's another thing called automaticity, another theory where as we automate and as we develop cognitive scripts and schemas, we develop pattern recognition, we no longer need as much attention to do the same activity. And so you see that on the left-hand side there, the box, it could be a PGY1 trying to sew up the wound. If you notice when they're sewing the wound up, they can't talk about anything else. And if you do ask them and you demand an answer, they usually stop doing what they're doing and they actually answer your question, and then they go back to operating. And that's what they should do because they don't have the capacity to be able to divide their attention. But as an expert or a PGY5 or a fellow or a staff, you can actually do two things at once, and you can actually multitask and still likely have spare capacity. And if you flip those graphs around, now we're experts and we just go to work and do what we do every day. We're now on the left-hand side. You know, even a hernia now after 10 years, or a Whipple after 10 years for me is actually an automatic, fairly automatic operation, where I relatively am in a routine mode, just kind of doing what I'm doing, unless there are kind of certain moments that I know are critical moments or something that actually comes up and is not quite right. So I'm just actually doing what I need to do on the left-hand box, and then the slowing down phenomenon is when you actually recruit your additional cognitive resources and invest them in what you're actually doing to slow down and to focus. And when you see the spare capacity, you can see that this is one of the reasons why we can actually observe this phenomenon in the operating room if we were observing surgeons, because they often have to take away from that spare capacity. So they often stop what they're doing. They can get irritated. Just conversations that were fine 2 minutes before somehow gets distracting now because they're now focusing on what they're doing. And this is just the cognitive way of being that we all have, and our brains work this way that we don't get taught very much. But this is actually it's becoming a fairly routine theory now learned in medical and surgical education. But I started thinking about this idea of the moment in surgery. So everything that we do in certain moments in surgery. So if we're gonna operate and we decide to cut something, if we divide the bile duct or the bile duct in a gallbladder operation, it happens in moments. And it became very interesting to me to start understanding what was going on in those silos of moments, if you like. What was going on in the surgeon's head at that moment when they send me this bile duct injury. Did they know where they were cognitively, what was happening in the room, what was happening socially, and how was the surgeon feeling? And that became very, my next kind of line of research. And as I interviewed surgeons, they often would talk about these moments of slowing down with other words that were not typically in the decision-making literature. My efforts during these moments of crises were consumed with the anxiety I was feeling and intermixed with feelings of inadequacy, uncertainty, reputation, and ego. A lot of words that we don't actually talk about too much in surgery or hear too much about, or maybe even explicitly train for. So I decided my next kind of decade after my PhD shifted from a more cognitive way of looking at judgment to trying to understand what are the perhaps sociological, cultural factors that affect our judgment also. Again, I used qualitative research when you can't count something and there's a phenomenon that happens in the social environment. You can actually do qualitative research, quite rigorous qualitative research, where you can figure out where the phenomenon exists and how you're going to actually get at that and develop a conceptual framework for it. And it's a very iterative process. You go into the field, you bring back data, you develop a framework, you take it back to the field, and eventually you've built a kind of a robust, I think, framework that the people who you've captured it from actually understand, and they look at it and they say, yeah, that actually resonates with me. Most of the methods are interviews and observations, and I use a particular methodology called grounded theory, where we're basically kind of building from the ground up with our co-construction with our participants. The first study that I looked at, and the first I want to share with you today, is this idea of when surgeons said, I can't believe I just did that, kind of reflecting on our errors and reflecting on what actually were the contributing factors to what occurred. And through my research, I developed a list of factors that affected us when we actually say, I can't believe I just did that, or you look back at what happened, or you made an error and you look back at it. You can kind of give me lists of things. You might say, I was tired that day, I was rushed that day, I was, used to be mindful, but I was kind of feeling a little bit distracted. I had back pain. I let the resident do it. I was teaching. There's a lot of different factors that become lists of things, but I actually found that, again, going back to this idea that how do we actually understand what's going on in the moment, and then how do we give ourselves tools to perhaps change what's happening in the moment, is what I wanted to do. And a list doesn't really do that. A list, when you're in that moment, doesn't really, you can retrospectively go back and create the factors, but how do I develop a tool or an idea or a framework for understanding the moment, and maybe even influencing the ability to change direction in the moment before accidents happen. At the time, I was reading about professionalism issues with Shifra Ginsburg. She's a medical or an internist at the Mount Sinai Hospital in Toronto. And she studies professionalism, and she characterized the behaviors in 3 buckets. And as I was reading this paper, I started understanding that my data could actually fit, a lot of this data could actually fit in these 3 buckets for how, what are the types of factors, or how could we actually characterize the factors that influence surgeons in this moment. So the first is the avowed. So these are the factors that we say could actually, we're doing it for the patient's sake. We make decisions because we think it's in the best interest of the patients. We'll go out and we'll talk to the family, and we'll talk to the the family and the patient and say, okay, we did this because it was in the best interest of the patient, and we're rarely challenged by it. We can kind of stand up in there and flag. We're in our M&M meetings or our QA rounds, and we talk about these avowed factors, and we try to construct often the story so that it's aligned with the avowed factors. This is an example perhaps of an avowed factor. I gave the patient a stoma. He didn't want one, but I really felt it was the best thing to do, the safest thing to do for him. And it's really hard to kind of fight that or argue that. That's what I felt was the best for the patient. But as surgeons, we all know that we're influenced by different things, and it's because we're human, and it's often because we're working in a very difficult environment. And to say otherwise or to ignore the other things that influence us when it happens to be kind of affecting our patients is just a little bit like putting the head in the sand. I think we all feel sometimes like we are alone in it, or other people don't feel like this, but I can tell you that a lot of these examples came out in our data. So if you think about what fits in the unavowed bucket, these would be things that we could talk to each other about, but we might not be able to talk to the patient about. You know, feeling rushed, teaching pressures, having to get to meetings, different things that we could actually say, yeah, I get that pressure. You know, that's the same kind of pressures I feel, but we wouldn't go necessarily to the patient's family and say, I was rushed to a meeting or I had teaching pressures. So these are the things that fit in the unavowed bucket. I think the pressure of the clock is distracting and you hurry things along. We know that it's the wrong thing to operate by the clock, but we're put in a position where we're in some ways forced to do that. This came up a lot. These kind of pressures of the clock, having to get the next case done. And then we have the bucket of disavowed factors, and these might be things that we may not talk to each other about, and we may not even want to acknowledge to ourselves. But again, these are things that are with us because we're human. You know, I make a living, I feed 4 kids, I need to actually put food on the table, I need to pay my rent or my mortgage or whatever. All of these things are part and parcel of the pressures of what we do. You know, I worry about my reputation, I worry about what other people think about me, that's human. So I'm not saying that this is surgical surgical only. These are things that we actually, pressures that we feel because we're human. Things like, there are ones like, well, do I really need this help? Do I want to seem like a loser? Am I going to call someone? You know, the decision to call for help. You know, when do we make that decision? What goes on in our minds when we're actually thinking about calling for help? You know, I called for help yesterday or last week. What's going to happen if I, get called for help today? Surgeons have talked to me about having this kind of this sweet spot of calling for help. You know, if you call for help too little, you're probably not a good surgeon. If you call for help too much, you're not a good surgeon. So we're all kind of thinking about, what's that sweet spot? Am I out of the sweet spot or I'm in the sweet spot? And I know that we're actually becoming more of a culture that actually encourages calling for help, but I think we still have a long way to go in terms of this. We judge each other. We actually are worried about how people are going to view us. And again, coming back to the idea of the moment, are there things that we can do in the moment to start asking yourselves and start asking ourselves, what is affecting my decision right now? You know, sometimes I'm sitting there doing a Whipple, and I want to do this Whipple today. You know, we're in a fee-for-service system, so of course I want to do the Whipple every day. But there are times when you think, okay, this might not be the right thing for the patient. You know, I may not be able to, right at the end, I think I might be actually leaving some tumor behind, or I'm not kind of convinced that it's going to be coming off, and I'm not going to get an adequate margin. And I think, you have an empty OR list next week, you want to fill it, so surgeons talk about putting, looking for patients to put in their OR list, not wanting to actually kind of give up that OR time, whether it's remuneration, whether it's reputation. These are factors that have come out of the data time and time again. And we might say, okay, you're an awful person for thinking that, and maybe some of those things you don't think. But I can guarantee you that a lot of this stuff has influenced most of us in the room. One of the stories I tell is a neurosurgical fellow who came back to work and was worried about how he was portrayed by the residents. He wanted to be the staff that let the fellows do the operating, and so he was operating with his fellow, and he thought the fellow was dissecting along, they were doing a middle cerebral artery aneurysm, and the fellow was dissecting along that. And then he was starting to feel uncomfortable, like the fellow wasn't doing it quite right or not in the right plane. And all of a sudden he kind of got into it, and he took over at that point in time, but the middle cerebral artery was damaged and the patient ended up paraplegic. And he says that every time he actually thinks about that, or is hemiplegic, every time he thinks about that, now he sees a patient come in a wheelchair, and he knows that he could have done something, or possibly could have done something differently if he hadn't worried about, letting the residents do it. And so we have fellows that come by, or residents that come in to train, and we don't talk about some of these explicit pressures that we actually go through. And so we're all left individually to kind of navigate them or negotiate them, rather than actually making these explicit, or perhaps putting even systems in place to kind of acknowledge it and to support that. Another thing I heard, phrase I hear commonly, is this idea that we remember all of our deaths. And as surgeons, we've talked about having our own graveyard, and we know that we actually do things sometimes that harm patients. And I think we all remember very vividly when that happens. And so we also wanted to understand this phenomenon. Do surgeons react a certain way? How do surgeons talk about it? Was I alone in it? Am I actually not cut out to do this? And one thing that I started feeling, as I said, as a resident, was that I'm unique. This is not something that other people are sharing or other people are feeling. But one thing I learned about myself and others, and as I've talked to surgeons a lot over the last decade, that I'm not unique by far. And I could not actually find a surgeon, or I have not been able to find a surgeon that doesn't have these reactions. Is it a gendered thing? I think I often ask that as a female surgeon. Am I only experiencing this because I'm female? And so I had to have females and males in my sample. And if you ask the females, because you're female, does this have something to do with your reaction to complications? And they'll say, absolutely there is. Females think that it's because they're female, they feel more, they care more, and they feel that makes a difference to how they react to complications. But the men, when you go into them, they say, who sent you to me? Did you hear that I'm an outlier? So they actually also feel like they're a little bit different, but we attribute it to different things. So I attribute it to being a female, you attribute it to being an outlier, but we also, when you actually get down to it, we're all actually experiencing very similar things, but we just don't talk about it too much, and we have different ways of perhaps externally showing it. If you look at these, if you say to me, okay, there are people in my department who don't react like this, you should go talk to them. So I can only speak on the outside, but they appear to have stuff slide off of them. Many surgeons wanted to tell me, go and see so-and-so in my department. You won't get the same kind of response. They're heartless, they're cold, they're callous. And so I actually did seek out all of those surgeons in our department, and I can tell you that it was not the case, that it maybe took a little bit more time to actually get at them and get them talking about how they felt. But eventually they started opening up and talking about it. And often, actually, an hour later, I was trying to get out of the interview, and they were felt like it was a bit of therapy for them. The head of surgery at the time was talking about kind of early retirement, because he actually found that the complications, or his reactions to complications, were getting worse rather than better, and actually retired a bit early because of it. So what is the reaction? We actually labeled it as 4 different phases. It's particularly in the acute phase, 3 different phases, but we actually added a 4th phase. The kick is the first phase, where you hear about your patient that has not done well, whether they've had to been moved to ICU, or they've dropped dead on the floor, or they have to go back to the OR, they've got blood in their drains. Whatever it is that you hear, you get that initial kick, that physiological kick. And what is it? How do surgeons describe it? There's tachycardia and there's unease, anxiety. I'm not entitled to walk around with my lab coat and my scrubs and be a surgeon or a scientist or whatever. You just feel personally devalued. So there's an imposter syndrome, I think, in many of us. For some reason, we think someone's going to actually find out we're not as good as everybody thinks we are. You kind of want to run away and hide in the corner and be alone. And I think this is kind of characterized by a sense of shame. We should have known better. Why did we let that happen? Other people would have actually done something differently. and very emotional. I almost crashed into 4 parked cars before I got out of the parking garage that day. I was so distraught. Like, I'm not a guy that cries, but and incapacitated. So you're dealing with the emotional turmoil and that morbid feeling of you've done something bad, and it generally incapacitates you. And the second phase is what we call the fall. So this idea that you sense yourself falling or you sense yourself spiraling out of control, you don't like the feeling, and you're trying to make yourself feel better. So you're going to grab onto something that makes you feel better. And this is kind of marked by this earnest search for what actually happened. And this question is, was it my fault? How much of this was my fault? Did I goof something? Did I miss something? Is it a technical problem? So I relive the operation and I go through the critical parts of the operation. And the third phase is the recovery, where you actually sense that, what was one of the surgeons said, the pall has lifted. In this study, we also followed surgeons around in the acute phases of complications and talked to them immediately after and then 48 hours after as well, to get the difference. And you could really see when this pall had lifted, because they started talking about their complications quite differently, and they started opening up a little bit more about what they perhaps did to contribute to it and what they might do differently. And so we kind of marked this phase with this idea of learning. You know, this is marked by a period of, a determination to learn something. I'm going to learn from this. I'm not going to dismiss it and say, well, it's the patient's fault or it's the nurse's fault. Sort of learn from it, whatever the problem was, and move on. And you can get up or not. If you don't get up, that's slow suicide or termination of what you do for a living. Surgeons describe different things. Some of them said, give me the next case. I need to get that next case done so I can actually feel better about it. I can do this. Give me the next case. Other surgeons said, I can't do that case for a while. Kind of give me a break. I don't really want to get back on that horse. I want to actually give it a break. So I think we react here a little bit differently. And understanding why is actually an interesting part of what I'm doing presently. And the final phase is this thing called the impact, where we actually recognize that surgeons, after a period of time and a cumulative experience of these in their career, can actually have an impact on them as people. And so we labeled this as the fourth phase, kind of more the chronic impact on the surgeon. I think that each mistake I make or each complication I have or each patient I bury, I think has taken a little wee piece out of me. It's that kind of obsessiveness on my side that's aging me at an incredible rate, affects my tolerance for taking chances. I get to a point where there are fewer and fewer cases that I get really excited about, like I see the very negative side of it, or the negative is starting to outweigh the positive. And I think what I've tried to do is ask myself, why do we have such significant complications? And I think one of the things that I've come up with is this notion of reputation. The truth is, you're also worried about yourself. I think really you're worried about your reputation, how people are going to think of you. The finger pointing, everyone in the community is going to know. And I think being worried about a reputation isn't a sign that we're bad people. It's just a sign of our culture. The fact that we actually have to worry about our reputation. And that we've heard other people are, being talked about when things have gone on. So I think the reputation is part of and should be owned by the notion of culture and the surgical culture rather than kind of the individual. Over the time, as I've talked to surgeons and a surgeon myself, I think that we set ourselves up to be like a super person. Having these ideals of what we think we want to achieve and who we want to be and who we want to be perceived to be, but the reality is sometimes we feel quite alone in it. And at the middle of the night when we're struggling in the operating room and we're kind of there all alone or with residents who we don't think are helping us very much, the feeling can be a lonely feeling. And a lot of the things that we do are actually very lonely. I mean, I had surgeons talking to me about going home after a major complication, people you would never think would do this in your institution, but kind of go up to their bathroom and kind of sit on the floor and cry because they've had this major complication. It affects us that badly, and I think we stay kind of very alone in it. So this thing gets stuck occasionally. So I've actually spent the last little while trying to understand some of these things, and rather than think of judgment as a cognitive construct simply that lives in our head, we bring judgment to the operating room. We teach people judgment. That's kind of a cognitive construct, a psychological construct. We also have to think about our culture and how the culture influences the way we think, and the culture influences our decisions. And for that, we need to actually go into other theories and other literatures to try to understand what that means. And I just wanted to share with you quickly 4 different theories that I think actually help us try to understand where this surgical culture comes from, and perhaps gives us some tools to understand if we want to change it, how do we change it? There's this theory called the constructed identity that I know we talk about people being kind of true surgeons, or we see medical students and say, yes, they're the surgical type, they should be a surgeon. So I think the constructed identity says that we actually construct these identities in each profession. If I got my second choice in my after high school, I had medicine was my first choice and music was my second choice. If I had got my second choice, I would be a different person now than I would be than I had got surgery. If I even chose anesthesia instead of surgery, I think I would have had a different identity. And so these identities are constructed in our training program, and as you kind of assimilate and as you go into your field and become one of the tribe. This is a constructed identity. And so what is the surgeon identity? I've asked surgeons this. This is some of the quotes. So someone who's knowledgeable, confident, decisive, and walks with their head held high. They have that like strut, that like surgeon's walk. You're not supposed to be afraid. You're supposed to be in control. You're supposed to know everything. You're supposed to be able to do it. So this is the identity when we have medical students or residents coming in. Whether you explicitly say this or not, this is often kind of what they pick up as the identity of the surgeon. And certainly if you ask the public, this is kind of the identity that the public have about us. But I think we're also influenced by that before we even enter surgery. There's another theory called the looking glass self, which I think is important in surgery and in our surgical training programs, that when we are branded by something, we often see ourselves through the lens of others. And that's what Cooley actually states, that if you surround yourself by people who love you, you feel better about yourself and you often achieve better. If you're surrounded by people who you think are questioning you or doubting you or don't think you're very good, you often underperform. You feel like you are not as good. That's actually kind of a direct link. And psychologists actually have another type of theory called that self-efficacy, which says the same thing. But the looking glass self, if we have trainees who we brand as bad trainees or surgeons that we brand as poor surgeons, it's very difficult to get out of that brand. As one of the surgeons talked about here, you have to have the confidence that you can do it. Everyone has to be on your side, and it's got to be a can-do kind of thing. Because if it's not, then people start to eat away at you. They second-guess you. Are you sure? Do you want me to call? And then you get self-doubt and lose your confidence, and then you can't do your job. And the third theory is this idea of performativity. Goffman talked about, he used the metaphor of acting to actually study the way we interact with people on a person-to-person basis. And he was very interested in talking about us as, and the whole world, I think in sociology and anthropology, talk about us as social actors. And we think we're just kind of being ourselves, but they see the way we interact with other people and how we put on a front stage for others, the way we want them to interpret us and the way we want them to understand us. So we put on a front stage that's sometimes incongruent with what our backstage is telling us. And so it's very interesting to watch us go along, and as I've understood this theory, if I walk into a medical director meeting and I have to try to be firm and confident, I can see I make decisions about what I wear that day. I make decisions about how I walk in and perhaps where I sit. You know, these are all decisions that we make and thinking about what impression we're actually giving. And this is actually normal. And what we don't do is actually teach people how to negotiate this or how to even understand this or be explicit about it. You know, patients, what do patients want us to be? You know, if we're too indecisive with some patients, what is that telling them? You know, should we lie and say we're confident? You know, those kind of things are, discussions that we should be actually having with our trainees and with each other. This was a colorectal surgeon who said this in an interview. It was a horrible case and I couldn't identify the rectum. I couldn't even identify the sigmoid. So I'm operating with a senior resident and thinking to myself, I'm a colorectal staff and I can't even identify the rectum. I'm not saying it to anyone else in the operating room. I'm like, God, I'm like giving the perception that I can tell what's going on here. I think I must have spent a lot of time doing nothing. During that time in the OR, there's probably very minimal going on in terms of actual operative patient care. It was like taking care of myself. And he talked about, the reason why he eventually called for help was that he recognized his colleagues were going to be coming in the morning and he'd be canceling the surgery if he didn't actually hurry up. And then he reflected on the idea that when he did call for help and he was on the phone, he actually acted very confidently on the phone so that the person on the other end of the phone said, it sounds like you got it, sounds like I couldn't do anything better, just kind of close. And then he was left wondering, was I acting too much on the phone? Maybe I should have just said, I really need your help here. So all these kind of ways we ask for help and how we construct the story about asking for help is also very interesting. Oh, just come and have a look at it. I sometimes will say to my colleagues, come and have a look. Actually, just scrub. It's very interesting. Come and have a look. Why can't we just say we would like you to scrub and give us a hand? And this fourth theory, this idea of socialization, how do we become these people? How do we become surgeons like this? How do we actually perpetuate some of these values into the next generation? It's a thing called socialization. And it's highly studied in the anthropology, sociology literature. People have studied surgeons, the socialization process, and it's very interesting to see how medical students or residents can come onto our services and very quickly pick up what is valuable to us, what we value and what we don't value. And they start emulating those behaviors. And then over time, it becomes internalized to yourself, and then you don't even know you're doing it, and you're just teaching it to the next generation. I stop sometimes myself rolling my eyes or snickering or doing something in the M&Ms. I know all about this, and I still sometimes find myself doing it. I more often than not speak up and I speak against this, but occasionally I'll find myself actually kind of being caught up with that flow and saying, haha, or like, someone should have known better. That's the socialization power and the socialization process. This is an example, a guy who was a surgeon, a senior surgeon who actually was presenting a case or talking about a case. When I presented my case, they laughed. As soon as one laughs, then the other laughs, and no one has the balls to not laugh. It's almost like a little club. I'm thinking, does anybody have the nerve to not conform? No one wants to be the dumbest. No one wants to be the least informed or the most inquisitive. It's almost like when you have the big shots all together, you can't really be inquisitive, and if you are inquisitive, people laugh at you. And how does it come back to this idea of the cognitive capacity? I do think that surgeons have talked to me about this being kind of in a bloodbath or having kind of a very intense slowing down moment, which often feels like speeding up in the operating room, and being distracted by other thoughts like reputation, like, what is my mother going to say when she hears that this patient might have died on the table, or what are the family going to say when I go up, having visions of the family up there. I think what happens is that some of these pressures to measure up or pressures to be somebody that we perhaps don't want to be or can't be or feel we aren't, actually eat some of our spare cognitive capacity. And I think in the moment when we actually need all of that spare capacity, it kind of consumes some of it to the point that I think it actually impairs sometimes the performance. And I'll give you one example by a fellow. Two fellows were operating together doing a kidney transplant, and the junior fellow we were interviewing and reflected on this story. And then the staff showed up just outside the operating room to see how things were going. And I can see the fellow, he's talking about the second-year fellow, getting completely nervous and then completely changing and telling me, go faster, come on, you have to grab it. When beforehand we were just going at a normal sort of slow pace. He got nervous to the point that we ended up putting the kidney in upside down, so we had to take all the stitches out and put it back in again. And I think this kind of idea of pressures to perform can impact our patients. So the implications of a lot of this work, I've kind of sat back and I sometimes think, okay, where's the answer? How do we just maybe have awareness of this and maybe that's enough? Maybe we can fight it on an individual basis. What happens if we actually thought that we could change the surgical identity? So maybe the surgeon identity is not one that's kind of powerful and brave and strong and knows everything, but but maybe a more mindful, thoughtful surgeon. You know, what would that look like? How would that change the way we talk about each other? How does it change the way we actually present our cases? How would it change the way we actually round and the way we do our business? If the goal was to be a thoughtful, mindful surgeon rather than a strong, brave, fearless surgeon, how does that change things? And I think understanding the socialization process, we can change it. It takes time, but we can change it. The second implication, I think, is that I think having a vocabulary to understand some of these things does help. So instead of actually just feeling like I have all these things in my head, or I'm being influenced by these things, I don't like them, I don't really quite understand them, we can actually start to teach it, and people can start to understand that they are cut out to do this. And a lot of us are also feeling it, and here's a vocabulary to talk about it. And maybe if we can explicitly reflect on it, or now have a language to teach it, things might actually change. And I think talking to surgeons over the last decade, I do think that there are a lot of sick surgeons among us. You know, a lot of people are trying to be someone they're not, you know, who are worried about what other people are still thinking about them, even in mid-career and beyond. You'd think you'd kind of get over that, but I think there's still that kind of sense happening. And I think these pressures do impact our wellness. And there is a never kind of high burnout rate. I think we do have to think about what does the burnout, why are we burnt out? You know, yes, there are other factors, but what does this actually have to do with the reasons why we're burnt out? And what happens when we actually tell people that we actually need to take time off, or we need to actually step out, or what happens when we actually see a weaker surgeon? You know, how do we actually treat those people? How do we actually allow people to have the time that they actually need to be well? And so I think with the sociology theories that I've learned about, I think we could change the culture, the surgical culture. I think we could make it a safer culture. We could make it a more well culture. And I think it just takes some time, and all of us to go out into tomorrow and the next day to actually change a little bit about what we do. It's kind of one person at a time, the culture is changed. And yes, we can put systems approaches in places too, that would help. But we also have to kind of reach people from the ground up, or from the bottom up. Thank you very much.